I'm Zainab Sagir, and this is a rare presentation of tuberous sclerosis and cardiac hemangioma. Tuberous sclerosis is an autosomal dominant disorder resulting in mutations in one or two genes, TSC1 and TSC2. The genetic syndrome has a highly variable phenotype that may affect different organ systems, but the classic presentation includes facial angiofibromas, seizures, and cognitive impairment. Neonatal cardiac involvement includes cardiac rhabdomyoma and benign tumor compromising cardiac myocytes. Primary cardiac tumors are a rare clinical finding. Of those findings, 75% are cardiac myxomas, the most common primary cardiac tumor. Hemangiomas are the rarest form of primary cardiac tumors that are 1 to 2% of that. Tuberous sclerosis and cardiac rhabdomyoma is a well-established, oftentimes being diagnosed in utero. However, there are no documented reports of cardiac hemangiomas in patients with tuberous sclerosis. This is a 65-year-old male who presents to the ED with new onset palpitations and shortness of breath. His past medical history included paroxysmal AFib, hypertension and non-ischemic cardiomyopathy, and tuberous sclerosis. He was found to be in AFib, so a transthoracic echo was performed, and this showed preserved EF, but no atrial mass was seen. He was then discharged home with a scheduled AFib ablation. During catheter ablation, the initial cardiac survey demonstrated a right atrial heterogeneous tumor attached to the intra-atrial septum. Thus, the catheter ablation was aborted. A TE was then performed, confirming a mobile mass attached to the intra-atrial septum, which you can see in the picture. Cardiac MRI further revealed a single right atrial mobile mass attached to the fossa ovalis via a thin stalk that measured 2.2 by 3 by 2.3 centimeters. There was minimal vascularity and no late gadolinium enhancement present on the MRI. At this point, atrial myxoma was the leading diagnosis, secondary to anatomical and case presentation. In anticipation for the removal of this mass, the patient underwent a diagnostic left heart cath, which showed no coronary artery disease, and the mass was successfully excised and sent to pathology. The final pathology revealed a CD31 positive cardiac hemangioma with extensive hemorrhage. The patient did require extensive post-physical therapy, but is expected to make a full recovery. Tuberous sclerosis is a well-established genetic syndrome that can be associated with cardiac rhabdomyomas. Cardiac rhabdomyomas and hemangiomas occur in similar anatomical locations, so it's important to consider all possible diagnoses before committing to a treatment strategy. Cardiac hemangiomas are a very rare primary benign tumor of the heart, and making up only 1 to 2% of all primary benign cardiac tumors. Patients typically are misdiagnosed initially, and only after excisional biopsy is performed will true diagnosis be confirmed. Due to the scarcity of primary cardiac hemangiomas, there is no clear indication for surgical excision or operative techniques, so keeping a wide differential is really important for optimal treatment. The atrium is the most common site of hemangiomas. However, clinical symptoms and image findings of atrial masses generally lack specificity for one tumor over another. Despite hemangiomas being the most commonly seen in the right atrium, myxomas make up far more primary right atrial tumors. And so without specific pre-biopsy findings, the cardiac hemangioma diagnosis will be missed. In a literature search in 2019, a total of 67 articles representing a total of 65 cases of atrial hemangiomas had complete operational information. Of these patients, there were no patients with tuberous sclerosis, further showing how scarce this is. Overall, characteristic cardiac findings of tuberous sclerosis include rhabdomyomas, a benign tumor that often presents with multiple lesions. There is no documented tuberous sclerosis presenting with intra-atrial hemangiomas in the literature. Due to the overall rarity of cardiac hemangiomas, especially in the setting of tuberous sclerosis, optimal management isn't well established compared to more common atrial myxomas or rhabdomyomas. Optimal identification and treatment of primary cardiac tumors is an ongoing field without clear guidelines. And for the most part, people with atrial myxomas are asymptomatic, and there's no need to remove it unless it's actually obstructing flow. On the other hand, cardiac hemangiomas are of surgical concern with high incidence of complications if not removed, further highlighting the importance of correct pre-surgical diagnosis. Further delineating cardiac tumor pathology before extensive operative removal will benefit the patient outcome despite the scarcity of hemangiomas.